he would be talking on comparison of spot photoscreener and automated refractometer in differently abled children. Is he there?
Good afternoon. Good afternoon. I would be talking to you about comparing the spot photoscreener and the automated refractometer in differently abled children. We all know that differently abled children are generally neglected with the respect of their vision and visual acuity testing because they're generally not brought to any eye hospital, and more of their systemic abnormalities are given preponderance. And the automated refractometer is generally used as a standard screening tool in any eye hospital for detecting refractive errors. It is heavy and it requires patient cooperation, and it measures only refractive errors. Whereas the spot photoscreener, it has a no-touch technique, it's light, it's portable, detects amblyopia risk factors along with refractive errors. It's based on the principle of photoretinoscopy to detect refractive errors, and also uses cameras to get the fundal reflex and denote any misalignment of the eyes. It measures risk factors such as refractive errors, anisometropia, anisocoria, media opacities, strabismus, and ptosis. Our purpose was to assess and compare the efficacy of the spot vision screener with the automated refractometer in 35 differently abled children. So this was done at a special school in Chennai. 70 eyes of 35 children were tested. After doing an anterior segment evaluation with torch, they were subjected to the spot autorefractometer at 1 meter distance under mesopic ambiopic light in undilated pupils. And 3 readings were taken, of which the highest reading, which was with the spherical equivalent of less than or equal to 0.25, was taken. Based on the AAP guidelines, they were classified as pass or fail on the spot itself, and they were recommended a complete eye examination for conditions such as hyperopia, myopia, astigmatism, anisometropia, anisocoria, and any gaze abnormality that was present. Then the patients were given cyclopentolate and tropicamide and dilated, and then they underwent the refraction using automated refractometer under normal ambient light with dilated pupils. Again, 3 readings were taken, and the highest reading were taken of that. Those children who failed the spot test were brought to the base hospital, and after a thorough ophthalmic evaluation, they were given glasses or amblyotherapy as required. A 1-month follow-up was conducted at the school itself to know the follow-up and the compliance and feedback. Our results: we tested 10 girls and 25 boys at the school, and we had a 100% acquisition rate using the spot. The mean age was 9.2 years, and the children were between 3 to 15 years of age in that school. 1 child was already wearing prescription glasses. The clinical spectrum varied from mental retardation, Down syndrome, autism, cerebral palsy, and 2 children had seizures. The spot screener is based on the AAP guidelines. The other guidelines that was given by Donohue was the AAPOS guidelines, indicated in the red brackets. This uses the AAP guidelines because it is more stringent and gives us higher sensitivity. Based on these guidelines, 17 children were classified as failed, of which 28 eyes had astigmatism, 9 eyes had myopia, and 3 eyes had hypermetropia. 4 children had anisometropia of more than 1 diopter, and 2 children had squint, 1 with ESO and 1 with EXO. So when we compared between the AR and the spot, we saw that the AR could not give us the reading in 16 eyes because the children were not cooperative, while the spot gave us a 100% acquisition rate. So this video shows us that the child is quite uncooperative. He's not able to understand how to place his chin on the autorefractometer, and we could not get the readings right. The child is again being tried to show. But in the spot, we see that the child is just made to sit at a 1 meter distance, and we immediately get a full reading with the complete eye examination recommended. On calculating the spherical equivalent and plotting it on the Bland-Altman plot, we saw that it compares well with the autorefractometer readings, and everything was within the mean plus 2 standard deviation values. The spot actually underestimated hyperopia but overestimates myopia with a significant p-value, but the overestimation of astigmatism was not statistically significant. Arnold et al. Has compared 4 photoscreeners and shows that the spot has 80% sensitivity rate. When we compared other studies done with other kind of photoscreeners like plus optics, we found that the spot gives us 100% acquisition rate, and it gives us better sensitivity with spheres, but better specificity with cylinders. So to conclude, I would like to say the spot is spot on. Technically, it's no touch, quick, it has a very easy learning curve, and detects all the amblyopia risk factors and gives us reliable readings. But above all, it is child-friendly, non-intimidating, and requires minimum cooperation. Hence, an effective screening tool for differently able children. These are my references, and this was the team that went to the special school for the study. Thank you.
Thank you for a good presentation.
Thank you, ma'am.
And my question is that you have found that the acquisition rate with the spot screener was much higher than with the refractometer.
Yes, ma'am.
Is that right? Now, once you had an acquisition rate, I believe 17 of your patients, they failed the test. And you found the various amblyopia-genic factors in them. What about those who did not fail the test?
Those who did not fail the test did not have any refractive errors, ma'am.
So
they did not have any gaze abnormality. Their eyes seemed to be fine with the spot test. So their spherical equivalent was less than 0.25, plus and minus. So they did not require complete ophthalmic evaluation.
You see, you talked about sensitivity and specificity. So for testing sensitivity, you have to compare the results that you have got with something that you consider gold standard. Because your spot screener detected 17
yes,
as fail.
Yes, ma'am.
And according to you, all those 17 had something or the other.
Yes, ma'am.
How do we know that those who passed the test, they did not have any abnormality?
That's what, ma'am. This can only be used as a screening tool. It's not the specificity was high only for cylinders. So the cylinder values which came with the gold standard AR, that came with the AR and the spot were the same. So we found that the spot and the AR gave us similar cylinder readings. But the spheres it was overestimating hyperopia, underestimating myopia. So those is that's why it has a high sensitivity rate and a reduced specificity rate.
You try to understand what I'm trying to tell you. I'm not trying to put you down. You understand that? When you are testing sensitivity or specificity or of any instrument, right?
Yes, ma'am.
You have to find out what all those that you have found positive, how many of them are false positive, how many of them are false negative. And even in the negatives, there might be some which you have missed.
Yes, ma'am.
You understand?
Yes, ma'am.
So without testing it against a gold standard, you cannot talk about sensitivity and specificity. Your instrument, the spot screener, is good in terms of being child-friendly, in terms of having a high pickup rate. Right?
Yes, ma'am.
So that is the conclusion that comes out of the observations that you have described.
Okay, ma'am. I will look.
I hope I am clear.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Now, one question. These differently abled children with severe mental retardation or moderate retardation and autism, all these children will not cooperate for this type of work. So, is there any occasion where you have used general anesthesia to examine them?
No, sir. Not for the spot or for the AR, we did not use.
It is very difficult for all the children to cooperate. They are sometimes very aggressive, and also they do not cooperate at all.
Once they were brought to the hospital, they were
cerebral palsy.
At the community setting, we did not use anything, sir. Most of the children cooperated for the spot. All the children cooperated for the spot, and 16 of them did not cooperate for AR. Or those who failed the test, when we brought them to the hospital, they underwent a complete ophthalmic examination and examination under anesthesia if required.
No, the selection of the children is only through the institution or outside also?
No, sir, only in the institution, not outside.
Thank you. Thank you.
Thank you, sir.
So on the basis of your study, that the spot screener, we all know that it is more friendly, require less of intervention, and it is very quick. You do it quickly, so it is a good screening tool. So, would you recommend it even for the non-physically or mentally challenged children as a screening tool?
Yes, ma'am. We've actually done a study on 1,200 people in our hospital itself based on OPD. We've compared them also with the spot and the automated refractometer, but that is still on the go. This was a pilot study that we did, so we are still doing that. That is still on the go for any person who walks into a hospital, be it child or adult.
Very good. Your plans are very good, but do include a test whichever you consider gold standard to calculate your sensitivities and specificities. Good.
Thank you.